Top Med Talk.
This piece, Hemodynamics, State of the Science, is chaired by Desiree Chappell, CRNA from Louisville, Kentucky, board member for ACER and Top Med Talk's lead presenter. Featuring Monty Mython, Top Med Talk Editor-in-Chief, Smith's Medical Professor of Anaesthesia, Critical Care at University College London, with Tim Miller from Duke University Medical Centre and Dr Simon Davies, Consultant Anaesthetist at York Teaching Hospital NHS Foundation Trust. Have a listen.
Monty is a founding member of EBPOM International. I don't know if you guys knew that or not. And a founding member of EBPOM USA. So we are all in this room primarily because he and the team over in the UK decided that this was something that was important for us to do and for the world to start talking about. So I'd like to introduce Monty Mython.
Thanks very much, folks. A couple of little shout-outs. One is that someone's walked off with my dongle for the laptop, which is probably one of my most valued assets here. And in it is a little black thing that allows me to change the slides. So if that person could look around and see if they've got one of these white things that plugs in with a black little thing in it that's mine, I'd be really appreciative. If that person's already gone home, thanks. The second thing is a shout out for EBPOM, Evidence-Based Perioperative Medicine, which is 21 years old this year. Our first meeting, if you look on these things that are around as you go out through the door, at the bottom, there's a place called Dingle, which is in the deep southwest of Ireland. And if you've seen some of the recent Star Wars movies, that's where they found Luke Skywalker. Because if you had all the powers in the universe, you'd choose to go there. Okay. So if you want to come and join us there at one of our overseas meetings, southwest of Ireland, London in July, there's some tennis thing going on called Wimbledon around the same time, and some event called the 4th of July. We celebrate the 5th, actually, which is a bad joke, but it's actually when the NHS was. It's actually when the NHS was founded. That's what it really stands for. And then this year, for the first time, we have a meeting, for example, in Singapore, which is in back end of September, around the same time as something called the Rugby World Cup. If anyone knows that. Anyway, there we go. That's in Japan. Right, hemodynamic state of the science. So I'm going to tee this up a little bit, and then the panel's going to come and join us on stage to check off little bits of this as we go along. Simon, I think they want you to get a lav on, buddy, if you've got one already. So if you go nip to the back there with round this way. Right, some potential conflicts of interest that relate to this. I will refer at the end to a technology made by Edwards Life Sciences that you're going to hear more about in the sponsored session later on, but only very briefly. So, where do we stand with enhanced recovery, for example? Well, enhanced recovery is at least 20 years old. So this is early publication from Professor Henrik Kellett called Multimodal Approach to Control Postoperative Pathophysiology and Rehabilitation, published in the British Journal of Anaesthesia in 1997. So interesting to note, colorectal surgeon publishing the British Journal of Anaesthesia about postoperative pathophysiology and rehabilitation. And in it, he talks about things like pain management and fluid management. And in talking to Professor Kellett about it, I think he had to publish in the BJA because the surgeons really weren't that interested at the time in those things. And particularly when he started to talk about the fact that it was more about getting people up and about and eating and drinking than where you put the stitches in. He's kind of really lost them at that stage. The second one was in, sorry, I know we've all changed. Certainly the anaesthesiologists weren't interested. Second publication I could find was by Doug Wilmore and Henrik Kellett in the BMJ in 2001. And Doug Wilmore, as I understand, is a surgeon from Boston, so a USA surgeon and a Scandinavian surgeon writing in 2001. And then the next one I could find about major surgical patients was Tony Senegor and Connor Delaney, publishing, I think, in the year following this. So here we are, about 20 years later, and we all now think enhanced recovery is normal. And hemodynamic management is a recurring theme. You would have heard it in all the presentations earlier on today, whether it's restrict crystalloids or goal-directed therapy or whatever it's called, it's in there. So where do we stand on hemodynamic management in the era of enhanced recovery? Well, this is a selection of infographics. You can access them freely online at www.poqi.org. They're all published in Perioperative Medicine. Let's say 3 infographics here that summarize the endeavors of the Perioperative Quality Initiative, working with the American Society for Enhanced Recovery. And on the left-hand side, as you look at it, there's a risk-adapted matrix we'll come back to in discussion. There's a hemodynamic framework in the middle that we'll come back to in discussion. And on the right-hand side shows the continuum of fluid management that goes from the NPO, no NPO, let's have some liquid beforehand, through the bowel prep question, through choice of monitoring, through to probably the most important things, which is immediately post-operatively get the IV down as quickly as possible. Because collectively, we're really, really not very good at intravenous fluid management. The very rare person is, but most of us just ain't very good at it. So if you let the patient drink, you can forget about that. It's much better. Then the final bit is drink, eat, analgesia, move, sleep, which is dreams and get them home as quickly as possible, ideally without an IV, and then everything should be fine. So our first question, where the panel's going to come up and join us, is if we think fluid management is a key component. Tim, you're going to come up as well. Desiree is going to come back and host us. Is a recurring theme, is if one of the opening gambits in hemodynamic management is, this is an anaesthetized patient now, so this is quite anesthesia provider centric. I know our surgical colleagues are going to have strong views on this as well, but this is what's going on while you've got your head down doing the hard yards. Which fluid should we be giving to our patients? And I kind of think when it comes to the choice of crystalloid, when it comes to saline versus ringers, for example, that we finally answered a question here. Now, the reason I think we finally answered a question is because these two publications appeared in the New England Journal of Medicine last year. Now, I know you're going to push back and say it wasn't in the operating room, but this was in the emergency department and the ICU. It's a single institution step-wedged cluster randomized trial of around 17,000 patients. And in this trial, they concluded that the patients who got saline had a worse outcome. And the outcomes they found that were worse were the things that had been identified in the large human observational studies, in the preclinical studies, and in the animal models. And that's basically renal injury. So, Desiree, gentlemen, do you agree?
Absolutely. I think we've known this about saline for decades. I remember a talk you gave a while ago that said if saline came out today, it would never be passed by the FDA or any other regulatory committee. Yet we continue to use it. And we've had hints that saline's been bad for decades. We know the chloride load is excessive. We know the sodium amount is probably a little bit too much as well, but mostly the chloride load. Is chloride bad for you per se? Well, it may affect your renal perfusion, so yes. But the worst thing is that we treat the acidosis the chloride causes. And so we get into this cycle. Your basic success is a bit off. It's all due to chloride, so let's give some fluid. And it gets worse. And we give more fluid. And we go round in the spiral, down and down and down. And we haven't had the hard evidence to say to colleagues, look, just stop doing this. But I think this is definitive. It showed harm from saline, and we should just stop using it well, not stop using it. There is still a role in some patients for saline, but the majority of patients, just enough.
Completely agree. And I think we've had animal models that high chloride causes renal arteriolar vasoconstriction. We have, and now we have observational data that get increased in acute kidney injury, use of blood products, use of bicarbonate. Massive studies from the Premier database, and then we have these two studies. And for folks that don't exactly know what a randomized cluster wedge study design is, I think it was very eloquent, and I think it can be applied to a lot of peri-operative medicine where you have a degree of equipoise. So they basically said that if you come into our intensive care unit or emergency department in January, you'll get normal saline. February, you'll get balanced fluid. March, you'll get normal saline. And you very quickly, without having to randomize at an individual patient level, get up to large numbers of patients, 17,000 in this instance, and you get a clear answer that there's harm associated with normal saline, and you get it published in the New England Journal, and we can all say that's done deal. And I think it's a very eloquent study design. And Dan Sessler did a similar design with oxygen in the operating rooms. January, you get 35% for every case in your institution. February, you get 80%. So we've got equipoise as to which is better, and you very clearly get to an answer, and they got to the answer that it made absolutely zero difference in surgical site infection. Again, quickly getting to large numbers of patients.
So for someone from the UK, is it used much in the US, saline?
I don't know if I can speak for the US. It's not used at our institution. Is it used in the US? I think probably yes. Is it used on medical intensive care units?
All the time.
is the primary fluid. And John Myberg, they're doing a big study. What's the name of the study again? It's
something like balanced. But there's
a large study of comparing normal saline and balanced solution in Australasia. And before they did that, they did a survey around the world to see what current practice in critical care units. And normal saline is the number one used fluid. And this was a few years ago. So there's still work to do on change. But as far as I'm concerned, I think the evidence is there.
So before we go on, obviously there's someone that is not like everyone else. So I'm the one with the accent today on stage. Is that right? Surrounded by my favorite Englishmen.
I could tell the story about my daughter if you want. I listen to Top Med Talk in the car. It's either Radio 4, which the kids hate. Radio 4 is an old person radio that I like to listen to, or Top Med Talk. And my daughter, who's 11, Sophie, is in love with the voice of Desiree.
Oh my God.
She thinks it's awesome.
Well, thank you.
Signed photographs are available.
No, they're not.
We have the T-shirts, Nancy.
So we have here one of our panelists, Dr. Simon Davies. Simon, tell us where you're from.
I'm from York in the UK, and York is about 3 hours north of London. And the further north you get, the nicer it becomes. So come and see us. And I've been there for as a consultant for about 10 years. I trained there as well.
An anaesthetist.
An anaesthetist, yes. I was going to say anesthesiologist to the language barrier.
I can speak the language.
And we're a medium-sized hospital. We've about 800, 900 beds across 2 sites. And yeah, I did my training there. Met a guy called Jonathan Wilson, who was one that sort of founded optimization, his trial back in the 90s, and he was my mentor and kept me there for, since ever.
All right, great. Well, thank you so much for crossing the pond and joining us today. And we all know Tim Miller from the last session from Duke University. That's great. Do you want to continue to
There's a Slido question coming about half normal saline. I presume we'll bundle into that things like D5 half and alternatives. I think here we're talking about your primary starting fluid in a case that you would also turn to for volume resuscitation. But also, do you at times use lower salt solutions?
Very much so. Mostly post-op. An average colorectal patient probably comes out maybe 1.5 litres positive from the surgery, but that's enough sodium then to last them for many, many days afterwards. And so in the post-op period, then we'll use half saline or D5 saline just to reduce that sodium load.
Now the next question is the colloid crystalloid question. And I'm a lifelong believer in colloids, and my belief is weakening month by month.
Your love.
My passion is being overwhelmed by evidence, or maybe not. So this has just come out. It's e-published ahead of press. It is a dual centre, I believe, study, Andrea Kurtz Cleveland Clinic, and a centre in Europe, comparing colloids and crystalloids using a goal-directed approach, and they conclude there's absolutely no difference at all. So no reduction in a composite serious complications. However, there was also no indication of renal failure or toxicity, even though it was a starch that they gave. There's 2 possible messages there. Starch not causing harm, but didn't do any extra benefit. You've done a similar trial, Simon, in the past.
We did a few years ago, and the background to this, because we were proved completely wrong, is we were in the ASA in San Francisco maybe 6-7 years ago, on roundtable or the discussion about fluid management in aneurysms, and this aneurysm had 2-3 litres of fluid, and saying, what do you do next? And saying, give more fluid, give more crystalloid, and poof, idiots. Colloid is what you need. And we went into this trial thinking that colloid was better for you, particularly in terms of colorectal surgery. And there's some evidence that it is in terms of anastomotic perfusion in animal models. We did a randomized controlled trial, a couple of 100 patients, 0 difference between the 2 groups. No harm from colloid, but certainly no benefit. On the basis of that, we've stopped using it because of price.
But sorry, Tim, I just want to pick up in your trial, which people discussed a lot. There was a lot of rescue colloid given.
That's my point. Yeah.
Sorry. There was.
No, I'm interested in hearing about that.
Why did they need rescue?
Was it 30% had rescue colloid?
30% had rescue colloid. Some patients hit the maximum dose of starch afterwards. We had to switch to gelafusin. So if you gave colloid, you get less intraoperatively, and you gave more postoperatively.
Can I throw in a couple of little tantalizers? Because on the same page that you find this in anesthesiology, it's a fairly big trial. It goes over 1,000 patients, but if you want to talk to our big trialist people that say until you get up to 10,000, you can't really make decisions anymore. This is a very small trial, but got an infographic in anesthesiology, specifically addressing the long-term impact of crystalloid versus colloid solutions on renal function and disability-free survival after a major abdominal surgery. I'll blow it up for you, the relevant bit, in a moment. Now, it's small, 160 patients, but they found superiority with the colloid and no evidence of renal dysfunction. Actually, the kidneys seem to do a little bit better, if anything, with it. So disability-free survival, the higher number is better. So 79% of disability-free survival in the colloid group compared to 60% in the crystalloid group with a p-value of 0.024. And quite a marked difference in this HUDAS score of sort of quality of life as well. Did you notice that in passing?
I think this is an interesting study. I mean, it was they used machine learning to deliver their goal-directed therapy algorithms. They took humans out of the picture, and it's an interesting difference in outcomes. So I think overall we're at the situation now where we've got a number of studies that show no difference. We've got some studies showing colloids are beneficial. We've got no studies really showing colloids are harmful. So the adverse effect is the increased cost, which is significant, but in the overall picture of perioperative care is probably in the realm of less than 1%. So, and we've got animal models, as you say, that show colloids are beneficial, but we haven't got that level 1 large study that shows there's an outcome difference. We still use colloids. I'm in the same boat as Monty. I'm traditionally been a colloid user. I think the evidence is getting less, but we're still currently using them because there's still some studies out there that show benefit, and we haven't had any pushback from our institution in terms of using colloids on our outcomes.
Which colloid?
Albumin.
Albumin.
And it's very different. I know albumin is very, very expensive in the UK, and it is somewhat expensive here, but not as expensive as it is in the UK.
And that's actually what I was going to ask Simon really quickly. Do you use albumin or other types of?
No. Albumin is prescribed like a blood product. So it's very hard to get hold of, very expensive, and we just simply don't have access to it.
So what do you use instead?
Colloid. We don't use any.
Gotcha.
Mm-hmm. What did you used to use?
We used to use starches.
There we go.
Yeah.
So this is on the same little list on the right-hand side. You were alluding to it in coming into more trial usage. It seems that we as humans are so chaotic with our fluid management. We're so far off the mark when you look at the observational studies that we probably would overwhelm the benefits of penicillin if it had the same effect in treating. You know what I'm getting at? Is we're so chaotic, litres and litres out with trying to hit the target. This is where they've let the computer do it. Did you pick up on that one? So they've let a closed loop system administer the fluid, so the computer doesn't know what it's giving. There was
no difference in this one, was there? No difference in volumes given.
But there's a difference in the closed loop systems in outcomes. There is a volume distance consistent with it being a different type of solution. So when you do healthy volunteer experiments, colloids behave like textbook colloids. When you let the computer do it, it's closer to being a textbook colloid, and there does seem to be a benefit. When you get humans to do it, they're so far off the mark with the amounts they give and when they give it, it would appear that maybe you'll never detect a difference. You're involved in an AFM, as it's called, trial, aren't you, Tim? How's that going?
Yeah, it's finished. Can
you tell us the result?
But I think it's no.
Go on.
It's very interesting, and I think this needs repeating. And I think it's very interesting that when you use an automated system or a semi-automated system to have that closed loop delivery of colloids, they showed a clear difference. And yes, like any result, you get one trial. I think this needs repeating. But again, it's a very interesting finding.
Did they give more fluid earlier in the closed loop system? The timings of fluids.
I'd have to go back and look exactly at the fine print, but that's the big message from it. But so I'm going to take from that you start with a crystalloid, it's lactated ringers, And some people still have equipoise about colloids, but some people... Have you lost your equipoise about colloids?
No, I don't think colloids are harmful, but
Okay.
I'm not convinced they're beneficial either.
Would you do trials on them still?
I'll do trials on them still.
Do you have it? That's the equipoise question. Or have you
Yes,
moved on?
I would.
Okay, there we go. Right, what about how much fluid? And this one I think is fairly straightforward. The restrictors view, which seem to creep into enhanced recovery, in other words, I run my patients dry, or there's a magic number of amount of fluid, and therefore they'll do well because I never give them more than 1 litre or 2 litres. And somehow that crept in, which was never in the original teaching. A restrictor's view from the anaesthesia perspective is my patients look great in recovery, they breathe well and they go home quickly, which I think is true. But the silent killer is acute kidney injury, which is what you worry about afterwards. And I think in Relief we've had an answer to that now. 3,000 patient study conducted or led out of Australia, and New Zealand. An international trial, so 3,000 patients having major intra-abdominal surgery, randomised to zero balance, being the drier group, quite carefully controlled, compared to moderately liberal, which is about plus the 1 to 2 litres at the end of it. And there was absolutely no benefit at all in terms of disability-free 1-year survival with the more restrictive group, and no different to the liberal group. But the more restrictive group, the zero balance, had statistically significantly higher rate of acute kidney injury, and interestingly more infections. And that's what you would predict from this perspective. So I think that we can conclude that fluid restriction is bad in this context.
I think this terminology is very important. I think it's confused this field enormously. The original fluid restriction study was done by Brigitte Brandstrup out of Denmark, and the liberal group had about 7 or 8 litres, and the restricted group had 3 or 4 litres. So that was their original fluid restriction, just avoiding this recipe, 10 mils per kilo, massive amount of fluid. And gradually, as we've gone through enhanced recovery and we've been given more carbohydrate drinks, we've started translating this restrictive 3 or 4 litres into sort of zero balance 1 litre. You know, it's become cooler to give less and less and less. And I think Relief has nudged us the other way again, that we were getting too restrictive, we were harming the kidneys. And we're really, if we're 1 to 2 litres positive, 3 to 4 litres of fluid, that's not where the harm is. It was the 7, 8 litres that where the harm was. So I think we just nudged back into the middle and realised that, too restrictive can be bad.
But we all agree we should avoid crystalloid/colloid fluid excess. So that's a universal excess being defined as more than 2 litres positive.
Yeah.
Or more than 3 litres positive, maybe.
Yeah.
What do you think, Simon?
For most patients.
Okay.
I think if you're a low-risk patient, you haven't got any advanced monitoring on, which is perfectly reasonable. Your mortality risk is low, less than 1%. To aim for 1 to 2 litres positive at the end of surgery, I think that's a great target.
Yeah.
For the more complex patients with the more complex fluid shifts, with other risk factors that you have to take into account, I think then we individualise the approach using advanced monitoring.
I agree, and I think you can do that while still having an overall goal of 1 to 2 litres positive in mind.
Absolutely. I think if someone's fluid responsive on a monitor and they're 2 litres positive, you should be saying, well, actually, hang on.
Yeah.
We'll stop here and have a little think about things. So technology doesn't tell us what to do. It just aids our decision-making by giving us extra knowledge. You still have to have some common sense.
Yeah.
Completely agree.
So, Chair Desiree, have we nailed this one?
I think we've talked about it a couple times.
We moving on?
Yeah.
Okay, moving on. Right, goal-directed therapy. So someone asked on Slido, what does restriction mean? And I think I've hopefully alluded to that, is in this context, it meant to mean avoidance of fluid excess. We then got to the zero balance question, and now it seems to be +1 to +2 litres at the end of a case is good for almost every patient, as far as we can see. It's not a major problem, including with daycare surgery. So what does this goal-directed thing mean then? Now that means different things to different people, because the goal could be, I want the patient to be 1 to 2 litres positive at the end of the case. It doesn't necessarily automatically mean cardiac output monitoring, advanced hemodynamic monitoring. Whereas in this context here, in the Fedora trial, this is another one of the series of, I think we're up to over 90 trials now, of which many of them are single centre and many of them are small and therefore subject to potential bias. This is a Spanish multi-centre trial, 420 patients. It was actually stopped early, which may be a discussion point that we may not have time for, but statistically significantly improved outcomes in the so-called goal-directed group. Now, if we go back to the title, it's not a goal-directed fluid management trial, it's a goal-directed hemodynamic management trial. So the algorithm included in it addresses both preload in terms of optimization of stroke volume. Then it has a secondary layer which addresses both mean arterial pressure and cardiac index. So it goes volume, flow, pressure, volume, flow, pressure. And about 25% of patients, it appears, had an adequate index after fluid loading, but had an inadequate MAP. And at the threshold of 65, they had vasopressors, 25% of patients, started in an infusion form as opposed to a push, which everyone seems to get. And that group had better outcome on multiple fronts: less morbidity, shorter ICU stays, less acute kidney injury, less ARDS, less infections, etc., etc. So, goal-directed hemodynamic management. Do we think a holistic, carefully selected patient, that type of algorithm is state-of-the-art?
No. Sorry, no. It comes from the 1980s. Mm-hmm. We've come round full circle, haven't we? Schumacher's original work and Jonathan Wilson's work in the 90s was optimized flow, optimized pressure. And then, I don't know why, maybe because of change in technology, we moved to the Doppler, we weren't picking arterial lines, we didn't have that information. Goal-directed fluid therapy came around. It sort of changed from hemodynamic to fluid therapy, and we forgot about the pressure.
But do you think, my question is, have we moved to goal-directed hemodynamic management? In other words, are we considering all of those variables now?
Yes, and it's the right thing to do.
Yes.
We just forgot about it for a few years.
Yeah, so we got to factor in the pressure, which we'll come to in a second, and the flow, which we'll come to in a second.
Yeah, I completely agree. And I think the most important thing is fluids first, then pressure. We don't want to squeeze someone who's dry, but I think that we need to optimize fluids, and we need to appreciate the limitations of conventional monitoring, heart rate and blood volume. Can I tell your story of your study you did as a resident? I think,
yeah, sure.
If you're going to get emotion and tell a story, it's a way of getting a message across. So when Monty was a resident, he wanted to get some publications, as any young resident did.
That wasn't my motivation.
Yeah, okay. So they put arterial lines and 14-gauge catheters in himself, you can look at his own data, and his colleagues, and bled out 25% of their blood volume. And then they trusted one of their colleagues to give that back without it clotting in the bag. But what happened when they did that is their heart rate and their blood pressure didn't change. But to compound the misery, they also put nasogastric tubes down each other with what's called a gastric tonometer. And what do you think happened to the gastric pH when they bled out 25% of their blood volume? I see someone nodding. It went down significantly. Why is that? Because your body compensates for hypovolemia to shut down your splanchnic circulation, reduce your stroke volume, but maintain your blood pressure. So they were significantly hypovolemic, and the stroke volume would have been down if they were monitoring flow, but it didn't affect their heart rate and blood volume and blood pressure. So the gut was crying out, and that's the benefit of early of goal-directed therapy. You can measure that stroke volume, pick up those episodes of hypovolemia early, and prevent that hypoperfusion that you get from the gut.
This is what the Noblet study showed, wasn't it? Up in Newcastle, equal volumes of fluid given, so one control, one goal-directed fluid. But the thing that changed was with goal-directed fluid management, you gave that fluid early, and they showed reduced inflammatory markers, and the supposition was that you maintain that splanchnic circulation.
And the Benez study as well, which was similar, gave the fluid earlier, reduced lactate, even though overall fluid volumes at the end of the study were the same.
Yeah. This is a slide which I showed at EPOM in London in front of Paul Miles, who's the lead investigator for Relief. And it was agreed, although it's a little bit naughty putting two trials on the same slide, it was deemed appropriate if it's hypothesis generating. So let's be clear that that's what it is. So the blue boxes are the so-called restrictive, i.e. zero balance in Relief, compared to the liberal group. Now this is without hemodynamic, there's a subset of hemodynamic management using cardiac output, but broadly speaking, the trial is recipe book, if you see what I mean, combined with readily available hemodynamics. And the liberal group, the AKI rate goes down to about 5%, but in the Fedora trial, which is volume, flow, pressure, with all three targets, it's down to 1.5%. And the patients look, broadly speaking, similar risks, etc. So I think that's the current question, is comparing those two right-hand groups. Is that a reasonable, if you're running a trial, I think that's the trial you need to do, is those two right-hand groups. Moderately liberal compared to goal-directed with flow and pressure targets. Is that a reasonable question?
Yeah.
It may be, or it may be that there's just, the higher risk patients would benefit from the goal-directed therapy and the lower risk patients from the moderately liberal approach. Sort of a risk-adapted matrix.
So this is the hemodynamic framework, which came from the American Society for Enhanced Recovery and the Perioperative Quality Initiative. And the key thing in here, I think, is if you follow it through from is there a clinical problem, through to what do you think is causing the problem, through to using the hemodynamic variables, is the unusual pink-coloured sponge in there, Tim. What's that?
Any guesses? A brain, yeah. So use your brain. The machines haven't taken over yet. We need to be logical and sensible with how we do this and use our brain.
And then the three interventions that are proposed are preload, afterload contractility. So do you need some fluid? Yes, no. Do you need a vasoconstrictor or vasodilator? Do you need an inotrope? Simon, sensible approach?
All very sensible. Fill the patient up, if the blood pressure's low, give them a little squeeze, and then inotropes are always slightly unpopular, but they do have a role.
But I think in Fedora, only, was it 3% of patients need an inotrope? So it's rare, but it should be part of your algorithm if needed.
The 25% needed a pressor, which is what you'd that would go with your gestalt for regular practice, wouldn't it?
Probably more with an epidural.
25% of the patients, they were mostly low risk. What do you do afterwards? You're on a vasopressor now.
We use vasopressors fairly regularly in intraoperative, because we run quite a number of epidurals, and generally if we use goal-directed therapy and get the patients nice and full, we can generally find that as the patient wakes up, that vasopressor's fine to come off without them needing it post-operatively. Obviously, in the rare occasion they do, they'd have to go to a higher intensity area, or we'd switch out the epidural for a plain opioid epidural, but most of them we find that we can, as the anesthesia wears off, we can get that vasopressor off.
Yeah, we have issues with, or we've had issues with that in the past, in that people would just wean off the vasopressor. So they maintain the blood pressure throughout surgery, doing the right thing. And they get to recovery and think, well, bugger, there's no HDU bed for this person. What do we do? So we'll just turn it off. And then they go to the wards.
Our last few minutes, we'll just rattle through these last few points, because Simon, you're going to pick up on this in your post-lunchtime session. But in that, you're going to be talking about technology more than possible relationship between blood pressure and outcomes. We've seen a lot of large data sets now, and this one comes from the Cleveland Clinic, suggesting that transient periods of perioperative hypotension are associated with bad outcomes. This happens to be MINS, which is a myocardial injury and non-cardiac surgery, often a troponin rise, and acute kidney injury, with as little as 1 minute of a MAP below 65 associated with worse outcomes, and the lower it goes and the longer it's low for, the worse the outcomes. Now, those are associations, not cause and effect. But then we've had, as far as I know so far, just the one trial that specifically is badged this way, i.e. the Foutier trial, Paris multi-center, looking at targeting preoperative blood pressure using a norepinephrine infusion running pretty much from the get-go, and demonstrating that outcomes are better. So, do we think we should keep the MAP above 65?
Yes. I think we put out the pokey guidelines, so I can say that, and they're published online in the BJA. Dan Sessler led the group, and I think with the current evidence base, I think it's prudent to keep the mean blood pressure greater than 65.
Simon? If your preoperative MAP is greater than 65.
If your preoperative MAP is greater than 65.
Absolutely agree.
And I think we need to measure a preoperative blood pressure and get an accurate baseline.
So what about how?
The right way. I don't know what that is. I think with the Foutier trial, one of the important things was they were fluid optimized first.
Yeah.
Okay, I think that's the key.
So they all had cardiac output measured.
Yep.
And they were all given fluid boluses to maximize stroke volume before the norepinephrine infusion was started. So they're not giving...
You're not squeezing them.
You're not squeezing empty patients, as far as we can tell.
And that's hidden in the supplemental appendix of the paper. And I think that's a key message, that there's a real danger of unintended harm. If everyone thinks, oh, we've really got to be much more careful on the blood pressure, we'll start that phenylephrine infusion really early, and really squeeze them. And we won't be, if you're not monitoring it, you can't necessarily tell. I mean, you were saying the other day, I don't know where you got this statistic from, but you can keep the patient's blood pressure normal with vasopressors, and they can be 40% hypovolemic.
Yeah, you can certainly, in more controlled animal models, you can demonstrate that beautifully. You can have extensive hemorrhage, and you can make every number you measure go back to be completely perfect when you've got 40% of the blood volume in a bucket. You can make everything look perfect.
And surprisingly, even the lactate, completely normal.
Absolutely.
Yeah.
There's no clue. And so many people just don't get that you can make it all look beautiful.
So volume optimized first, and they gave at least 2 fluid boluses in every patient before they started the norepinephrine.
So I think we've done this framework, and I'm going to come to the left-hand panel in closing over there. Tim, we'll give you credit for this. There's a few other names on this paper, but let's ignore them. Talk us through that diagram for a second.
Yeah, I think this was a great paper that I wrote, and I think I think you reviewed this paper and said, I think we should add a risk-adapted matrix. And this is the one picture, of course, that everyone puts up from this paper. So I have to credit you with the risk-adapted matrix. But this was our original risk-adapted matrix, suggesting at the time we thought zero-balance fluid management was the appropriate thing for the low-risk patients. And as you get into higher either surgical or patient risk, we recommended individualizing that with goal-directed therapy. And in the highest risk group, considering post-op intensive care. And as I'm sure you're probably going to come on to, we have recently, myself and Paul Miles, just published in Anesthesiology, updated this after the results of the RELIEF study. And I think you noticed that, as we were discussing, in all patients aiming appropriately for 1 to 2 liters positive, but in those low-risk patients, not using hemodynamic monitoring, and in the higher-risk patients, again, using hemodynamic monitoring. But the general goal, I think, of not zero balance, but 1 to 2 liters positive in all patients.
And do you change your goals as the risk gets higher, both surgical and patient? So for one, we just use maybe SVV. For the highest risk ones, do you target oxygen delivery or stroke volumes?
I think stroke volume generally. Yeah. I think stroke volume variation has got so many limitations. We're using more low tidal volume ventilation, more laparoscopic surgery, patients with arrhythmia. So most of the sort of goal-directed protocols now are going primarily to stroke volume optimization. We're perhaps using stroke volume variation as just one of those variables that can give you a little bit more information, but not your primary driver.
Let me ask one question, because a lot of people do enhanced recovery here, and they have within their protocols built a lot of fluid, in their pathways have fluid protocols built in that use this matrix. And then they have to themselves make the decision, obviously, within the case, whether or not they're going to use it. For your enhanced recovery program at Duke, do you use the risk-adapted matrix for all of your patients? Do you not use goal-directed fluid therapy for your...
You're teeing me up here.
I know, I am, sorry.
No, so we've published on this, and then people say, what do you do? And so we actually do goal-directed therapy in all patients within our cardiac, within our enhanced recovery pathway. And so the obvious question is, well, you've just published this twice, this risk-adapted matrix. Why do you not do that in your institution?
Because you're a young doctor who wanted publication.
Touche.
And I think this is where the evidence is, but then there's implementation.
Yeah.
And there's a definite advantage to doing the same approach in all patients. So we have the monitors, we do the same approach in every patient, so we're not trying to guess what the risk is going to be. It's just the way we do things. When we have residents, CRNAs rotating through, this is the way we do our ERAS cases. We accept that the greatest benefits in the highest risk patients, but we do it for everyone to have a standardized approach. And so that's the way we've gone about the implementation, accepting that's where the evidence lies.
So we're coming very close to the close here, and I do want to show some of the Slido questions. I'm not going to linger on this, but a subject that's going to hear a lot about in the next couple of years is dehydration compared to hypovolemia. You'll see some consensus statements coming out press this year, recognizing the fact that you can be hypervolemic and therefore hypernatremic and hyperosmolar and be feeling thirst because your hypothalamus is telling you you're thirsty and what you need is free water. And if you don't get the free water, you can't pee out the salt. And I think a lot of us have forgotten that in our care packages. This is just one study we published where we empowered healthy volunteers who we dehydrated to rehydrate themselves using patient-controlled intravenous hydration. So we adapted a PCA pump and gave them some D5 half. Whoever asked that question, they could hit the button until they didn't feel thirsty anymore, compared to us giving a standard regimen that is supposed to rehydrate. And the person empowered to do this nailed it. They were absolutely perfect. Now, they were young, fit people without morphine, surgery, delirium, dementia, etc. But it's a space to watch. The final space to watch, which we'll come to after the lunch break, is artificial intelligence and closed loops. We referred to the fact that, Tim, you've led a multi-centre closed loop evaluation, which is now finished, but you won't tell us the results. And Simon, you've got extensive experience of HPI, which I think is the only approved artificial intelligence in this space, which is why I've mentioned a product specific here, which is from Edwards Life Sciences, as featured in the Wall Street Journal in an article, The AI Doctor Will See You Now, that generates this number in the top right-hand corner, which is a predictor of hypotension. Is that a reasonable summary about what you're going to tell us about later?
Yeah, pretty much.
So come with bated breath to hear the truth behind. Can the AI doctor possibly help?
Can we predict the future?
I think the important thing about closed loops is that we're not. It's a decision support tool. We're not taking away the role of anyone. It's just giving us decision support, which I think in a busy operating room is going to be the way of the future. You know, it's already adopted by a lot of industries, the airline industry, etc., which we're often compared to. And I think decision support is going to come more and more into the operating room and medicine in general.
So we can rattle off a few of these if we can, Desiree.
Yeah.
Does anyone know any data in cardiac surgery supporting colloids in non-hypoalbuminemic patients? Dan, do you know any?
I was just going to say Dave.
No, neither do I.
The early gold-rated studies that you did used colloids, but they didn't compare the two.
There's only one cardiac study that showed jelly fusion was worse, higher incidence of anaphylaxis and a slightly higher rate of AKI as well.
There's no large, definitive, pragmatic patient-centered
60
trial.
patients, maybe.
Hartmann's versus Plasmolite?
They're both balanced solutions.
Sorry, 1 second. Don't knock my 60 patient. They were about basic science, intermediate outcome variables. But you can speak. Tim,
So
Hartmann's versus Plasmolite?
They're both balanced solutions. The anion in Hartmann's is lactate. It's the same as lactated ringers. And the anion in Plasmolite is acetate and a bit of gluconate. They're very, very similar. If you've got liver failure or having a liver transplant, you probably want to avoid the lactate and maybe use Plasmolite. Plasmolite doesn't contain calcium, so you can use it with blood products. But they're both balanced solutions, both superior to normal saline for the majority of patients.
You can get low calcium with
Quick
not
fire,
too large volumes.
Quick fire, last few questions. If you have a low albumin pre-op, does it change your fluid choice?
No, I've only got one.
Tim?
We use albumin anyway, but I think, particularly it's a higher indication for using albumin, particularly if you get a SICU.
Does the MAP of 65 guideline apply to acute trauma patients in damage control surgery, or would you decrease it to 55?
The trials were all looking at major elective non-cardiac surgery. It doesn't include any trauma patients, so you can't really extrapolate.
So in the damage control thing, we're still encouraged to use a crystalloid to resuscitate to the presence of a large pulse, basically. Nothing fancy in the first round, and not even have a MAP target initially.
It's a different scenario, and for a short time you probably tolerate a slightly lower pressure. It depends on their preoperative blood pressure as well. But I think your primary aim is to reduce the bleeding in that very early stage.
Transthoracic echo?
Intraoperatively not hugely useful.
Pre-op point of care, transthoracic echo for fluid management planning. Any experience?
No, we don't.
Tim, any experience?
I think pokers can be useful generally if you hear a murmur or if you want to have a quick look at the heart preoperatively. In terms of fluid planning, not sure so much got a role.
So Dan, again, have you considered using urinary biomarkers for kidney stress to trigger GDFT in high-risk patients? Now, we've done a few interviews with John Kellum on TopMed Talk about this. If you want to know more about what is commercially known as nephrocheck, I can't remember the real scientific term for it, but
IGF-7
IGF-7 and something else that Dave and Dan can't remember at the moment. But so clever stuff that's in, and it tells you about kidney stress. It sounds very interesting, very potentially exciting. Have you had any experience yet?
No experience, but I read your paper on it, which I think was very exciting. You've almost eliminated AKI from cardiac using it. So Yeah, no, I think it's quite
Read
exciting.
the papers, met the rep, interesting area, needs more studies.
Would you use it? Yeah.
Potentially in high-risk
Why not?
patients. We talked about doing it in our liver transplant patients, which have a huge rate of AKI.
So, last question. What inotrope would you start with, not dopamine at 5 exclamation mark? Actually, my prejudice is we might see dopamine creep back into practice. For those of us who grew up with renal dopamine, it might be back, but we'll call it different, something different. We won't call it renal dopamine. We'll say, whole body dopamine. That's the one.
I lament the demise of dopexamine because that was brilliant, but probably dobutamine as a first line.
As your inotrope, yeah. Tim?
In reality, if we start off with giving a little bit of ephedrine, and then, I think dopamine really went out of favour because of the renal stuff, but if you just want a little bit of pep up and a little bit of beta, it's something you can give peripheral. It's not a bad choice.
So my tip is I think we'll see a renaissance. I've got no skin in that game at all, but I think perhaps that baby went out with the bathwater, but we'll see what happens. Desiree, back to you, man.
Yes, all right. Well, thank you again for joining us. We are going to be breaking for lunch now, and we'll see you soon.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done. And it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.